Welcome to the Newly Meds podcast. Any views or opinions expressed in this podcast are our own and do not reflect the views of our employers or affiliated organizations. This content is for informational purposes only. Always follow your local policies, protocols, and medical direction.
What is up, guys, and welcome back to another edition of the Newly Meds podcast. I want to start off today's episode by wishing a happy birthday to my partner in crime, Dan. It's awesome since he's joined the podcast, and today's his big day. So, Dan, before we get started, happy birthday to you.
Well, thanks, man. I appreciate that.
So today we got a really special episode in store for you. Dan has a pretty personal story that he's going to share with all of you. But we're going to talk about some neurologic emergencies today, and I'm not talking about your run-of-the-mill stroke. I'm talking about some oddballs that we see out in the field that, to be honest, most of the time we may have no idea what's going on, but there's some really key differentials that we need to zone in on in order to understand these neurologic emergencies that aren't your run-of-the-mill stroke or head bleed on a day-to-day basis. So, Dan, I wanted to jump into that. Yeah, go ahead, Dan.
No, you're exactly right. I was just going to say, I know a lot of the times we try to come up with things that we hear being questioned of, you see the stroke and we have all of the stroke assessments down and we feel like we have a pretty decent grasp on that. And then we see something neurologic that's not a stroke. And then we kind of are like, oh, what are we doing with this? So I think that's what we're going to try and get into with today's topic.
Yeah, it's one of the things that honestly confuses me the most when I was a brand new paramedic, and I think continually it still is a challenge in the field, is diving into something where, because the patient might have an altered mental status, you can't get a ton of information. And so these can be really tricky waters and murky waters to navigate, especially as a new provider. So hopefully this can shed some light onto some of the things that you might be seeing on a day-to-day basis in the field. So we're going to jump in, and Dan, why don't you tell us about this story that you have that's pretty personal to you that sort of opened this topic up for us?
Yeah, absolutely. So, a special shout out to my sister, not only because she's my sister, but at the end of every episode, we do say, anything that you guys want to hear about, we would love to talk about. And so in talking with my sister after one of the previous episodes, she suggested that we talk about her story a little bit. So we're going to start off with that. My sister is a nurse, was working at the time, my local trauma center on the trauma neuro floor, where she was assaulted by a patient being struck in the head. And we can talk a little bit more about assault on providers as well. But she was struck in the head and didn't think a ton of it at the time, had a little headache, and was ultimately, I believe it was the next day, was seen in the emergency department for kind of a persistent headache after that. Was ultimately diagnosed with a concussion at the time and continued to experience these lingering symptoms and progressively worsening symptoms, and was ultimately diagnosed with post-concussion syndrome. So we'll get into a little bit more what that looks like, what that actually is, when we get a little bit further in the episode here. But I do, like I said, I wanted to give a shout out to my sister for letting us talk about her story and kind of bring to light some of these neuro issues related specifically to that, as well as opening the door, like Will said, to some of these other neuro topics that doesn't necessarily fall within, your run-of-the-mill stroke or something to that effect.
Wow, Dan, that's such a powerful story, and I really want to thank your sister as well for sharing that with everybody that's watching and listening. And I think it sheds a lot of light on what happens in real life. As providers, oftentimes we may get assaulted, but not only that, these post-concussive blows and head injuries that occur at work aren't just from patient assaults. I'm a tall man myself. Dan is a lot taller than me, and I hit my head on the back of the ambulance all the time.
At least once a shift, yeah.
Yeah, at least, at the minimum. And so I think it's important to recognize that these head injuries, they can grow and build and develop into some pretty severe impacts. So, Dan, just off the top of your head, do you know if there were any long-term effects with your sister's injury, and sort of how did that shape you as a provider looking at it, working in healthcare and seeing your sister go through something like this?
Yeah, absolutely. And we'll get into some more of the symptomology later in that section. But to this day, this was almost 2 years ago, or actually this was over 2 years ago at this point. This was the summer of 23, and to this day, she still has issues with her speech. She still has some stuttering that's associated with that. She kind of has waxing and waning symptoms as far as, a good day versus a bad day. But on some of these bad days, she can have some pretty significant balance and coordination issues. She's sustained several falls, including down stairs, as associated with these balance and coordination issues. So she's still in a tremor as well with that, to the point where she has had to go back to the emergency department several times for kind of a cocktail, if you will, to try and get these symptoms back to a more manageable level. I think the most significant one, though, we talk routinely that she lives with just a current 5, 6, 7 out of 10 headache, and that is what she has established at this point, her quote unquote normal. That just is something that she lives with on a daily basis. And like I said, that was over 2 years ago at this point. And like I said, we'll get more into the symptomology and stuff like that with PCS when we get down there. But yeah, so when we think about like what that looks like from my end as a provider, how that's kind of shaped me looking at these neurological calls, I've had to call 911 for her, and anybody that is in EMS and is listening knows that we do everything in our power to not call 911. We definitely have the fix it mentality. I'll fix it myself, or I'll find a way to make this work on my own. And I've had to call 911 for her, just to the point where it was too unsafe for me to try and have her walk down the stairs, even with my assistance. And like you pointed out, I'm a large guy. I did not feel safe. Like if we had tried to walk downstairs, we would have both ended up going down a flight of stairs. So, when we think about that type of thing, the crew coming in, now fortunately, her being a nurse and her being very well versed in her, disease process, if you will, she is able to give a good history. However, that night in particular, her speech was so altered that it was incredibly difficult for her to communicate. Now, she was ultimately able to get this information out to the crews and to the nursing staff at the emergency department when we arrived there. But, fortunately, I was able to give that information to them. But if you think, coming in as a new paramedic, and you see a female who has, even though it's not at this point, super recent, has had head trauma, has just incomprehensible speech, stutters, coordination, balance issues. She's presenting with a lot of the stroke-like symptoms, and I believe on that time and several times she has been stroke alerted at the emergency department. So when we think about this from our standpoint coming into this podcast, is you're going to see things and you're going to have these types of patients where you see the symptomology and what else could this be besides a stroke? Because she in fact was not having a stroke. This was all just ultimately related to the PCS. I think that has opened my mind to exploring not only neurological, but other topics as well, but exploring these neurological topics more to try and get a better footing on what else could it be besides, the number one thought.
Yeah, and it's so easy. I think even when I was a brand new medic, but especially when I was an EMT, I think that as a basic, I fell into this habit of altered mental status stroke. And it's the easiest thing to do, right? Like your patient is altered, they have some sort of deficit, slurred speech, whatever, and you're like, has to be a stroke. And then now we're stroke alerting these patients that might not have a stroke. Maybe we're expending resources that they don't need, sending them to CT, sending them to MRI, sending them for whatever to try and figure out the cause when maybe it's something completely different. And that drives me to what we want to talk about in the bulk of today's episode, are what are some things neurologically that we misdiagnose in the field or overlook. And I want to start this out by something that I actually recently had seen in the field and was able to, just because of my own research on different topics, sort of narrow my list of differentials outside of a neurologic emergency, as in a stroke, and sort of get into the down and dirty of what could be going on with this patient. And so the first thing that I want to talk about is the acute toxic metabolic encephalopathic patients. And so when I think of TME, oftentimes I think of patients that are septic or have some sort of hepatic encephalopathy. And I think of these patients of recently having some sort of infection, post-surgical patients. And so what does that look like in the field? And so when I see these, oftentimes I see a little bit in the call that I had recently, my patient only was able to convey his name. That was it. But during his stroke exam, he was able to follow all commands. He was able to complete a full NIH stroke exam with really minimal difficulty. He just couldn't express what was going on. He couldn't express where his pain was. He couldn't express sort of the state that he was in, why 911 was called on him. But he knew his name, he knew where he was, he knew the date. He just, outside of your basic orientation questions, couldn't convey any information, but he was able to follow all commands. I said, squeeze both my hands, he could do that. So neurologically, from like a stroke perspective, he's passing all of these things, but something is causing him to be unable to express, and this sort of neurologic slowness that I was seeing in the field. And so as I examined this patient further, I found a distended abdomen. I felt that his bladder was really distended. I saw some medications on the table that revealed that he had BPH. And so it sort of gets you down this line of thinking of maybe he's retaining a lot of urine. Maybe he's got this really distended bladder that's, compounding these issues that I'm seeing. And maybe he just has some extra ammonia levels because of the true pathology of what's going on. And so when we think of this, you want to think about septic patients that can have the systemic inflammatory response that can give them this delirious or comatose state. And so then as that progresses, you could see some seizure-like activity, and the same thing with the hepatic patients that have all of that ammonia rise that I know for a fact a lot of providers that go to nursing homes probably see this more often than you think, and we're stroke alerting a lot of these patients when they might just have really large increase in ammonia. And especially the nurses that listen to this podcast, especially my med-surg nurses out there who are really in the trenches throwing that lactulose at a lot of patients with this hepatic encephalopathic, disease process, exactly what I'm talking about. And then the other ones that I think about are your uremic patients and then the hypoxic patients who have, again, brain injury from inadequate oxygenation and then toxins from the urine that can impair the kidneys, and then in that sense are going to impair your brain function. And so some of the clinical pearls that I have for you so that you don't miss these in the field is think AEIOU. So I think my alcohol, epilepsy, insulin overdose patients, uremia, trauma, infection, and then I start to go into my stroke patients, sepsis, toxins, and psychiatrics. And so as always with all your neurologic patients, check the glucose, check their O2 saturation, try to get as much clinical data as you can to narrow in your differentials. And I preach this to everybody. Before we start, intervening heavily on these patients, before we start throwing medications, we start doing different interventions, we should really collect as much data as we can. And that starts with doing a very good physical assessment. And I think, in my experience as well, recently with that patient who had BPH, had a bit of a distended bladder, probably had some sort of rising ammonia level or some sort of pre-sepsis going on, or the uremic patient, something outside of a stroke was happening. And if I didn't do a very thorough physical assessment, palpating his abdomen, looking at the bladder, looking at the medications on the table, I would have missed that in the field. And so I wanted to open that up to start. And we have a few more disease processes that we want to walk through that commonly are missed in the field. And so that's why it's so important. So Dan, why don't you talk to us about what else is missed?
Yeah, absolutely. I think you bring up a good point there, and I know we kind of hit on this in one of the previous episodes, and realistically, this is going to be a very recurring theme. I think one of the things that we do better collectively as paramedics, collectively as EMS, and collectively as healthcare professionals in general is a good history taking. We all go in and we all make sure that we're checking the appropriate boxes on whatever charting software we're using, and try and get, the general background. But we do need to do a better job of getting that full history, that full assessment. One big thing that starts with is the baseline mentation, right? Regardless of what it is that we're talking about, whether it be some type of encephalopathy, whether it be the next topic that we're going to talk about being delirium versus dementia. I know that is a trap that a lot of people fall into. We all have been there, self included, Will included, probably the both of us together at some point. Yep. Where we go to, local nursing home A at 123 Main Street. We have the address memorized, and we know where we're going, or to the memory care unit for the confused patient, and we all immediately groan and say, "Oh my God, yes, of course, the dementia patient is confused." Right? We'd be lying to ourselves if we said that every single person listening has it. Let's be honest. But that's not to say that that is the appropriate thing to do. That's not to say that that's the correct mentality to have. Just because somebody has dementia doesn't mean that they're all automatically immune from every other disease process, right? They can become encephalopathic. They can have other type of infections. They can have other type of disease processes that can lead them to an acute state in which they are altered beyond what their normal altered status is. So being old is not an excuse, or excuse me, is not a differential. Having dementia is not a differential. It's an excuse, right? We need to make sure that we are doing better with that. But when we bring up terms like dementia and delirium, what are each one of them, right? So we'll start with delirium. Then that is going to be your acute change. Typically, it's going to be secondary to some type of infection. We're thinking nursing home. It could very likely be a UTI, it could be pneumonia, could be any other type of infection, right? We can see delirium in our hypoxic and hypoglycemic patients, as well as any of these electrolyte derangements as well. Med interactions, overdoses, underdoses, withdrawals from medications. A lot of these different processes can cause delirium. And again, that's just it's going to be characterized by some type of increased altered mental status, right? It's going to have a fluctuating course, typically worse at night, could be during the day, but typically worse at night. They're going to have disorganized thinking, potentially hallucinations, inattention. But the key thing that I want you to think when we're talking delirium versus dementia in these types of patient is that rapid onset versus our dementia, which is going to be a slow progressive onset. Delirium, it's going to be hours to days at the most, but Pop was fine at lunch, and now he is picking at things while he's laying in bed. He's picking at things in the middle of the air that just simply don't exist, and he's hallucinating, and he's rambling to himself and is otherwise incoherent when that is not his patient. That is going to be your stereotypical delirium type patient, right? They can become paranoid, they can become agitated with these signs and symptoms. Other key things to think about with these, we've already established that this is typically going to be infection related, so look for that potential source of infection. Look for that potential UTI or pneumonia. Look vitals wise. Are they febrile? Are they tachycardic with that? Are they at this point hypotensive with that, right? Depending on how far this process has advanced, right? So I think those are the big things that we need to think about when we're thinking from the delirium side versus
and Dan, correct me if I'm wrong on this, right? But with the delirious patients, when we begin to treat them, the delirium seems to subside a little bit. Like if they have an electrolyte or a fluid imbalance or even the glucose, we begin to treat these patients and the delirium goes away. And I think, at least when I think about it, that's how I compare that and dementia as well.
And thank you for pointing that out, because that is one of the other, and I have in my notes here, and I just completely glossed over that, is that delirium, where dementia is not reversible, dementia is not curable, delirium is not only reversible, but exactly what Will said, as you start to correct what the underlying issue is, these patients start to show improvement. And I think that is one of the key things one of the multiple key things that we need to keep in mind with that. On the flip side of that, our dementia patients, like I did say, that is a progressive neurodegenerative disease. You are losing your cognitive ability, and that is not reversible. We all know that has memory loss, have executive function increase with that. You can have behavioral problems with that. And like I said earlier, this is going to be that slow onset.
Yeah.
Pop-Pop's fine at lunch and is now not fine. He didn't get dementia over dinner, right? This is going to be months to years. That's going to be that slow trending where you go out to the family where they've had enough, right? They don't know what to do anymore. They're at their wits' end because it's just slowly getting worse and worse, and each day is starting to get to the point where they are no longer feeling like they are able to care for their loved one.
Yeah, no, I think that's such a great point. Sorry, the phone ringing in the middle.
That's all right. All right. The big thing, the other big key points to take away, just in general, delirium increases mortality, especially in the hospitalized and pre-hospital elderly populations. And we're seeing that. I'll link the study as well. But noticing an early recognition of this delirious patient versus, again, just writing it off as dementia, writing it off as a confused old person. This early recognition is important. Why? Because it is simply we are having early recognition of whatever that underlying process is, right? So early recognition leads to early treatment, leads to hopefully early reversal of whatever that's going.
Yeah, I think that those two things are so huge, and Dan summed it up perfectly. Again, we want to make sure that we are getting the right differential diagnoses to understand these patients better. So when we think about our delirious patients and our patients with dementia, we really want to examine, how long has this been going on? What else is inside of the actual process here? Is there infection or something that is, if you're having trouble sort of differentiating the two, again, it goes back to the theme that we talked about earlier and doing that good, clean physical exam and investigating so that you don't miss things. And that leads me into the next thing that we want to talk about, which I think we could have probably 50 episodes on, and it's something that I'm really, really passionate about, but it's your patients that have a seizure and this post-ictal state that they're in. And I think that seizures are so complex, and there's so many different types, so many different presentations. The post-ictal phase itself can be vastly different from patient to patient. And so I think it's really challenging when we see it in the field to nail this one when we encounter it. But the post-ictal state is really any sort of altered consciousness and neurologic dysfunction that follows a seizure. And so it can be anything from a few seconds or minutes to hours, and it can be very long in some patients. And so commonly we're going to see these patients have some sort of confusion, disorientation, they're lethargic, they might have a headache, they might be combative or agitated with what we're doing to them. And then again, they have some neurologic deficits sometimes when they're post-ictal. So they might have some unilateral weakness or some slurred speech, facial droop, and they could have some incontinence. And always check the mouth in case you need to suction it. And if they bit their tongue or have some bleeding sort of that's going on, we always want to make sure we're managing our airways. And so with these post-ictal states, it can be really hard to recognize and identify exactly what's going on, especially because patients that are in a post-ictal state aren't going to be communicating with you. And I think you're going to see in today's episode that many of the patients that have some sort of neurologic impairment are not going to be communicating with us in a reliable sense. So it's really going to come down to obtaining the data in a clean and concise way to narrow your differentials. And that's the theme we want to get at here is we're not trying to make a singular field diagnosis. We're trying to get these differentials narrowed into what could possibly be going on that's not your run-of-the-mill stroke. And so clinically, we want to remember that these patients can get mistaken for intoxication or a psychiatric episode, especially if they're combative with you, or even post-neurologic stroke patients. They could get misled here with the post-ictal state. We want to keep in mind that, go ahead, Dan, yeah?
No, you're good. I wanted to just say, I think one of the most important reasons that we're bringing this up too is that, sure, you have a call in which family was there, they witnessed a seizure, the patient has a history of seizures, family is on top of things, they say, yes, he had a seizure, this is typical or atypical presentation of what his normal seizures are, right? That's all fine and good. But what happens when it is, I came home and my loved one has no medical history of anything, and now he is lethargic and confused, and I don't know what's going on, and that loved one just so happened to have his first seizure and it was unwitnessed and we don't know. Or we go out to one of our displaced folks, if you're in the city, like Will said, those routinely can get misdiagnosed as alcohol or as some type of overdose. What if it's not, right? What if this is something neurologic that we're missing? And again, just making the lazy excuse of, okay, well, he's homeless, therefore he's drunk. Oh, that's not how this works, right?
Yeah, I think that anchoring bias is so real. Like we have to understand that every patient that we see, depending on what demographic we're in or geologic location we're in, right? Like we have to get out of the mindset of saying it has to be this, right?
Absolutely.
Like if I work night shift in a city that has a major drug problem, they have to be overdosing, right? We get called out for a, high priority fall or a high priority unconscious person. And how many times do you hear your partner sit there in the station? Oh, they're just overdosing. You know what I mean? Like we have to get away from that.
And Will can attest, I am no better than anybody else. I have done that. We had a paramedic student one night that asked if they should ride along on it was a dispatched cardiac arrest. It was younger. The age dispatched was younger, I believe, early 30s, and it was in a known drug area that we routinely go to for overdoses, right?
Yeah.
And I even made the comment, said, you're more than welcome to come along. This is most likely an overdose, which you have done thousands of even outside of clinical hours. You're more than welcome to come along. And turns out it was absolutely 100% not drug related and was a very critical call that would have been very beneficial for that paramedic student.
Yeah. And Dan, how hard was it for you when you got on scene? Because I think this is such a real conversation and a real thing that happens. How hard was it for you to switch your mentality from, you're en route to this call going, gosh, another overdose. And then you get on scene and it's a high priority, critical, legitimate medical emergency, cardiac arrest. Like how hard was it for you to flip your mindset from like, oh crap, this is something real?
I think fortunately I have developed the ability to flip that switch pretty easily. The ability to walk in, and while I might think that going somewhere, and I'm not saying that I'm perfect by no means, but I think I might think things like that going somewhere, and then when I get there, I do try to keep an open mind. I try to keep fresh eyes and get what's going on. And like you said, it is that oh crap moment where, fortunately, it was as soon as I walk in and as soon as you hear as soon as you hear the start of the report, and it's like, okay, this is not at all what we thought we were doing, and we're doing all of the things, and this just went from, what we thought was to be a relatively simple routine call to now we're running a full ACLS mega.
Yeah. No, I agree with you. And I think, from my experience, I would get dispatched to, especially as a new medic, like only MICU, where I was, you get dispatched to some class 3 calls, you come in with this anchoring bias, and sometimes it's really hard to flip your mentality of like, I think I'm running a routine class 3, like I'm just going to be driving, should be easy, to, you get up there and the patient's pulse is 20 and I'm prepping the pace and I didn't bring in my monitor because it was a class 3 call, and even though I'm on a MICU, let's just bring in the BLS gear because why not?
I don't know if you were referencing anything, but shout out to one of my paramedic preceptors on, I believe, my first call at this station overall, where we ended up pacing a lift assist, or excuse me, a class 3 fall, a low priority fall.
Yeah, exactly. And I think it's, to sort of reel us back into the neuro discussion, but it's exactly why we talk about stuff like this is because it can be very, very detrimental to not only you as a provider, but to patient care when we sort of have these, innate things that we're doing that don't seem huge, and then they make a world of difference when we start doing them the appropriate way and the right way, and patient outcomes improve from that significantly. And so I just want to say on the seizure topic in these post-ictal patients, we were talking about the anchoring bias, and that's how we got here. And so the big thing is to remember that not everything that you see that's, combative or aggressive is always psych. It could be post-ictal. It could be a post-seizure patient. And so oftentimes, these are going to mimic a lot of other neuro things we see. They're going to mimic strokes. They could mimic intoxication, drug overdose, hypo or hyperglycemia. So always do a thorough assessment. A big thing that I check for on a lot of altered patients is just doing a quick examination of the mouth and oral area and just see if there's any blood. Did they bite their tongue? Is the tongue twitching? Are their eyes twitching? Some subtle things that you may see with like an absent seizure, but just some small things to pick up on in my assessment before I immediately say, oh, this is a drug overdose or a stroke or, some run-of-the-mill neurologic emergency that you think it is, and it's completely the opposite direction. And that leads me to passing the torch here off to Dan again, talking a little bit more in depth about your sister's story and talking about some, post-concussive injuries.
Yeah, I think when we think neuro, we do think more, especially from a pre-hospital standpoint, we do think more of the acute side of things. However, like my sister's story, there will be times where we will have chronic and or acute on chronic issues that we have to try to identify. And so like I did mention, my sister was ultimately diagnosed with post-concussion syndrome, which is an overall diagnosis that is kind of a catch-all of symptoms, neurological symptoms, right? Headache, dizziness, cognitive fog, irritability, mood swings, sleep disturbances, speech disturbances, executive function disturbances. Basically, any of these neurological symptoms can kind of fall within this constellation that is PCS. The symptoms can persist beyond 4 weeks, beyond 3 months. And that's when usually you start to see that progression of symptoms. It's not typically, at the moment that this injury occurs, but up to 4 weeks before you start seeing any type of real symptom development. And I think that's what's super important when we think about, well, why does this chronic issue matter to us? It's pre-hospital. And it is, again, like I mentioned, my sister was punched one time in the head, and the gentleman is not Mike Tyson, right? Not saying that it was not an insignificant injury on the, on the face of it, but it's, you watch football, and I think that's where we kind of think you watch football and you watch boxing and you see the sports and other events where people are hit in the head repeatedly and are presumably fine afterwards, and you're like, okay, well, why when you hit your head on the bar of the ambulance, why is that a concern? These seemingly minor injuries can legitimately turn into lifelong issues. And I think one of the reasons that I wanted to bring this topic up is that is another area that we can do better in EMS as far as patient education goes. You have that quote unquote simple head. Have that person that fell, hit their head a little bit, their head doesn't hurt now, they're otherwise fine, they don't want to go to the hospital. Well, studies are coming out with in regards to PCS is that a lot of these aggressive or more aggressive rehab type therapies are substantially more effective if they are started particularly within 10 days post-injury. So again, Will hits his head on the grab bar in the back of the ambulance and says, I'm fine. And we say, okay, sign here, press hard 3 copies and let him go. We need to be having these conversations with our head injury patients. We need to be having a lot more than just this conversation, and that can be a whole other topic as well. But we need to be having, as part of our conversation with these head injury patients, about the possible concern of this developing into this post-concussion syndrome, And again, these types of rehab, aerobic exercise, speech therapy, occupational therapy, and other types of rehab programs within, they call it the Buffalo Protocol. And that's kind of part of the concussion protocol in general. But they are substantially more effective initially within that 10-day window post-injury. Now, that's not to say that there can't be improved outcomes with therapy regardless of the window, but they're seeing the most recovery within that. There are also some more emerging treatments with that as far as neuromodulation, transcranial magnetic stimulation. There are other treatments that are being researched and being trialed as well. But I think, like we talked about at the top of the episode, seeing this on a personal level, seeing this with a loved one, and thinking, hey, if we don't just and I mean we have come to the point where I don't want to say we write concussions off. We're very stringent about concussions, and we're very cognizant of that. But I think a lot of times we say, oh well, if it's not some type of brain hemorrhage, it's probably a concussion, and you'll be fine in a week, right?
Yeah.
And I think we need to use, I know I have, and I think we collectively need to use this, my sister's story as well as everybody else that's been through this, to, hey, if we can, even if it seems, silly at the time, kind of get into this rehab mindset, even if there doesn't seem to be anything to rehab. I think we can hopefully do our part as EMS to get that education out there and hopefully start that early.
Yeah, and I think to sort of expand off of this post-concussive injury, Dan mentioned it earlier, when we have these repeated head injuries, the concern is this CTE. And if you've played sports, I played lacrosse my whole life. I've had many a concussion, many a head injuries, and we've even progressed from, I can remember being fairly young, and the concussion protocol was like a computer test and 2 days rest and no homework. And to now we're in this, especially with pro sports, we start to see this bubble and the protocol being a lot better and a lot longer. And you're almost out for 2 weeks, making sure that you don't repeat a head injury, that you don't get this second blow. And so when we think of CTE, it's this chronic traumatic encephalopathy. And this is a progressive neurodegenerative disease that's linked to the repetitive head trauma. So blow after blow, and it doesn't even have to be that big of a hit. When I bump my head and when Dan bumps his head off the grab bar, if we do that once a shift, 10 shifts in a row, we're starting to get in a pretty high-risk zone for these lifelong injuries. And so the important thing to note is CTE is never diagnosed when we're alive, at least not yet. It's something that is done post-mortem, and they examine the brain and they start to see these tau protein deposits in the brain. And so that's how we go about diagnosing CTE. But the clinical presentation occurs while we're living, obviously. And so some of these key clinical features that you would see with your post-concussive patients and also the CTE can be easily misdiagnosed in the field as something that, is maybe we're just thinking it's a stroke and it's someone who has had these repetitive head injuries. And so I think some of the things that you want to consider when you think about PCS and CTE is that the post-concussion is typically, a few days or weeks after the trauma, and the CTE occurs years down the line, and it starts to worsen. And it's a lot like, a little bit like dementia, where it, worsens gradually and is progressive. But I think most of the research is seeing it in these younger adults, and they call this early onset dementia. Sometimes I feel like where these patients start to gradually worsen and have this neurodegenerative effect. And now we're starting to see it's because of this trauma. We can see a lot of irritability or anxiety with PCS, and in the CTE, I think we start to see rage, depression, paranoia, and I think sometimes in the field we might even write that off as delirium. And so we need to be able to recognize some of these conditions. The cognition in your PCS patients is foggy, distracted, and in your CTE, they have a true memory decline, and they may not be even able to speak with you in an appropriate way. So recognizing some of these signs and symptoms that are associated with repetitive head trauma, concussions. We need to start recognizing these in the field so that we can get these patients the appropriate care. And I think as medicine progresses, as we start to look at these concussive blows and injuries, and the further we get, we've seen how advanced the medicine has already become from, a short time in a concussion protocol. When I was in middle school playing lacrosse and high school playing lacrosse, it was still only a few days off. And to now we're like, hey, you got to take 2 weeks off, maybe more, because of how serious these head injuries can be. And so, again, I want to just leave all of you with some pearls from me is we don't want to confuse these really aggressive and rage patients for psych. It might be a war veteran who has multiple head injuries that now has CTE, or a former athlete that's now in their late 30s, 40s, 50s that are in this really aggressive episode that you might say, oh, this has to be a psych problem, and it could just be CTE. And then asking the history, ask about head trauma, repeated falls, head injuries. Did you play sports? Are you in the military? All these things that can contribute to head injuries. We want to make sure we're asking for that. And then looking at patterns, looking if the family's noticed anything trending in this patient. Has this gotten worse? Is this something that's brand new? Making sure we're asking all the right questions. And so the big takeaway that I have for this episode as a whole is making sure that you're doing the good, clean, thorough physical exam, and that includes what's happening in the house or the nursing home or the street where you are. Your physical exam doesn't always stop at the patient. It needs to continue into the surroundings. What else is going on here? Try to develop a full picture and try your best. The one key thing that I have is try your best to eliminate the anchoring bias. And I'm just as guilty of it as Dan, is, try to get away from I'm not going to bring the cardiac monitor in on this class 3 call. I think that this is an overdose, and start looking at the whole picture. Try to come into every call with an open mind and try not to just get yourself into a diagnosis. Oh, this has to be a stroke. They're altered. Oh, this has to be, hypoglycemia. They're on the floor and the wife's on scene saying he's a diabetic. Try to look at the picture as a whole, get a vast list of differential diagnoses, and grow from that list and start to narrow them down. And don't forget about the things we talked about today that you might miss in the field, and that are often even misdiagnosed in hospitals. Remember to always try to get the full picture, and don't just slap a generic diagnosis on something because you saw one single presentation of it one time in your career. So now the next time you see it, it must be that. It has to be that. So that's sort of what I have on my end. Dan, what do you think?
I think any of my previous partners can attest to this as well. I am a strong supporter of talking to your partner, talking things through with your partner. I don't care if you're a medic I don't care if you're the medic on a medic EMT truck. I don't care if you're 2 EMTs, 2 medics, PHRNs. I don't care if you're in the hospital. Talk to your coworkers, talk to your partners. Physically ask, what else could this be? Like I said, my previous partners can confirm that. I will say, hey, in these types of calls, this is what I see, this is what I hear, this is what's going on, this is what I've got so far, this is what I'm thinking. What else can it be? What are your thoughts? And just regardless of certification level, they could have picked up on a clue that you completely missed. One of my previous partners caught, while I was doing something else, caught what she thought was, in the moment, quote a little weird, with a little tremor in his hand that was just kind of transient, right? A little bit down the line, this patient ended up having a full-blown seizure, ended up getting RSI'd, and she was either an EMT or an AEMT at the time. I don't remember what it is. Your certification level doesn't matter.
Yeah.
You have eyes, you have a brain, you can totally pick up on things that I might miss, Will might miss, whoever your partners are, again, across, regardless of what your certification level is. Have that conversation with your partners. Not only does that help get other ideas out there, but that helps break these anchoring biases that we're talking about. Have flow charts in your, either whether it's physically written or in your brain. Have sets of data points that you want to get on every single patient, or at least every single patient with like neurological presentations, and make sure that we are getting those every time. Don't be the person that, misses the blood sugar. I know this is an overly used example, but don't be the person that misses the blood sugar on a patient with a blood sugar of 35 because you thought Emil had a UTI, right?
And I think a great thing to do, and something that I was really fortunate to do with Dan as he was going through paramedic school, and as I was a very, very green paramedic at the time, and we even brainstormed the podcast and brainstormed a lot of things. One of my favorite things that I still do with my partners to this day, and that I would do with Dan on a constant basis when he was riding with me on a truck, is we would get dispatched out to something, just something really generic, or even something where we think it's just another overdose, whatever. I would always ask Dan, if I'm driving or he's driving and I'm in the passenger seat, what else could this be? I would just look at him and I'd say, Dan, what else could this be? Like, if we're thinking it's one thing, I want in my head to prepare the worst. And I think it got us both into a lot better of a mindset going into the call, rather than saying like, oh, this is just going to the nursing home, for a fall. We're going to pick her up and take her right across the street to the hospital, to, man, maybe she had a seizure because her medications weren't given, appropriately today, or she missed a dose or something. What else could it be? I think it just opens the door to really open your mind to what could go on in the call that you might not expect.
And I think on that point, in addition to those conversations, especially, and I think this is a very useful tool, regardless of if you're a veteran or in paramedic school right now, but especially if you're in paramedic school, any students in general that I've had in the past will know that I will say, on your way to the call, look at the protocol associated with that call. I don't care if it sounds like a routine chest pain. Read that chest pain protocol from top to bottom on the way to your call, as much as you can, right? Know your protocols for your medication. When you might take, this step versus when you might go a different route, regardless of what the protocol is, right? And by having that protocol fresh in your mind, that has that check sheet fresh in your mind, and that also kind of keeps you in a mindset of, this could go all the way down to the bottom of this page, and I need to be ready for anything that's on this protocol page. And regardless of if it's a chest pain scenario, whether it's one of these scenarios, whatever it is, having that fresh immediately right on your mind, I feel personally helps kind of break any of those anchoring biases as well. Because, yeah, sure, I might say, oh, maybe it's just dementia, or it's just a UTI going in, but now I have that full altered mental status protocol fresh in my head, and I have read the AEIOU-TIPS mnemonic on the way there, and thinking, okay, well, yeah, sure, we're going to rule out stroke, we're going to rule out hypoglycemia, but what if it is an electrolyte drain? What is some type of infection, etc., right? So I think those are really good ways to try and keep the information fresh in your brain and kind of break that anchoring bias.
Yeah. And I think the one thing that I want to leave everybody watching and listening with today is, if you're going to take away something from these neurologic emergencies, we've talked about the assessments, we've talked about a bunch of different things. The patient that I alluded to earlier that had some sort of neurologic emergency that I wasn't convinced was a stroke, and then did a further exam on it, his vitals were completely normal. And I think sometimes with these neurologic patients, you're going to see normal vitals. And I urge you to not write off that patient. I mean, it's a patient looking at me straight in the eyes with a really unremarkable vital set. A good blood pressure, sinus in the on the pulse. I put him on the monitor, normal sinus rhythm, did a 12 lead, got all of my diagnostic data. And I could sit there and be like, there's nothing wrong here, other than the fact that he really can't express to me anything outside of orientation questions. There's nothing wrong. And it's a really bad mindset to get into, that if your vitals are normal, your patient's normal. And so always be investigating and treat everything as a clue. Do your best to find as much information around you and gather as much information on that patient as you can, because just because something looks, smells, tastes, sniffs normal doesn't mean it is. You should always, in the back of your mind, have that worst case scenario here that this patient's going to crash on me at any minute, even if their blood pressure is 120/80 and their pulse is 76 and their SpO₂ is 99% on room air. Always, always, always have that slight itch in the back of your brain of something's not right here. There's a reason these patients are calling 911 or families calling 911. They're not just calling because of nothing. They're calling because some sort of change is occurring. So that's the big thing that I want to leave everyone with. And I'm sure Dan has some more insight too.
No, I think you brought up a great point there. You get that itch in the back of your brain. You get that gut feeling. Trust that. Go with that. Everything seems normal. His vitals are normal, and so he has to be right. But like deep down inside, you feel that something is off. Go with that. Don't. If you have any question on whether this patient might go a different direction than you were initially thinking, if that thought is crossing your brain, that's probably because the patient is presenting in a way that leads you to believe that. Trust that gut feeling, trust that thought process, and continue to investigate that. And when you said investigate, that makes me think of kind of a pet peeve of mine. Again, no better than anybody else listening, I 100% have done this. We all go to that nursing home that we talked about earlier. The nurses and the nursing staff scatter. You can't find a person to give you a report. You can't talk to anybody. Nobody knows anything. The printer's jammed. They can't give you paperwork. I get that those are all very, very, but I think a lot of times we use that, or family being a poor historian, use those as crutches to not further investigate. The information is there. Yes, it might be frustrating. Yes, it might be annoying. Investigate. Go get that history. If you have to go while your partner is with the patient or while you're with the patient and send your partner, if somebody has to go and stand there and physically babysit the nursing staff until they can figure out how to print it to get you paperwork if you can't get a report, then that's what you have to do. Don't use these excuses of, and again, while very real, don't use this as a crutch, as an excuse to be lazy. Make sure that we are legitimately putting a good faith effort to get as much information as possible.
Yeah, 100%. So to close out today's episode, we really want to hear from you, our viewers and listeners. What are some of the weirdest neuro calls that you've encountered in the field? Comment below, email us, let us know. We'd love to talk with you more about it. And maybe, like Dan's sister, she listens to the podcast. Maybe you guys have a story for us that we'll invite you on and you want to share with other listeners and viewers. So don't forget to follow us, like us, drop comments, send us emails. We absolutely love hearing from you. It's what drives this podcast. It's what drives us. We want you to engage with us just as much as we engage with you. So Dan, if you don't have anything else, that's it that I have. Do you have anything additional for the listeners?
Nope, I think that'll close it out. I think just like we've talked about, make sure that we are always going in and attempting to do as much as possible, keeping our main goal and our main focus, which is the patient, right? Do what is legitimately best for that patient in the moment, and we'll be good from there, right? So regardless of whether it is an acute or a chronic presentation of these neurological issues, always be questioning. You find something that you don't know what it is. When you come back, Will and I have talked several times about the office that we would talk about all of these things in. That's one of the things we would do too. We would see weird presentations, or somebody would say that they have a disease process that neither one of us have ever heard of. And we would sit there and, while it's still fresh in our mind, look it up, because that builds that repertoire, that builds that knowledge foundation for potential further occurrences with this type of process, whether you're ruling in or out. So I think with that, just make sure that we are getting good histories. Trust what you know, treat what you're seeing. Always remember to stay curious and stay humble.